Great.
Okay. So Debbie, would you like to tell us a little bit about your background?
I would love to. First of all, thank you so much for this warm welcome. And I am so thankful to be able to share a little bit about my own experience with this disease. And I will, in a moment, share my screen and share a bit about our journey as a family and with this disease. I live in Baltimore, and so I'm not too far from some of all of you. And I'm very grateful to have this opportunity. I'll take a moment to say that although I am a nurse and I love to share a lot of experiences in that regard, I'm not an expert in this disease, and I'm not pretending to come to you in that regard. I do have a lot of information to give you that I have gleaned from the experts. So I will give that caveat to you right from the outset. And much of my information has come from the Myasthenia Gravis Foundation, and they are a wonderful resource. So I trust that you can refer to them in the future as well. I am grateful that you are willing to learn more about this. June was Myasthenia Gravis Foundation Awareness Month, and I am so grateful that when I first began talking about this, you were open to learning more, and I hope you'll see why in just a few minutes. But I'm going to take a moment to try to let you all see my screen now, if I can figure out how to do it. Let's see.
So Debbie, if you bring your cursor down to the bottom, it should bring up the toolbar.
Yeah.
And in the middle, it should say share screen. Go ahead and click on that.
Right. That's what I thought, but I'm in the
And then
view.
it will bring up a couple different screens. So if you have multiple tabs open, it'll
Right.
bring up whatever
Okay.
tabs you
Here we
have.
go.
Okay.
I've shared the screen, and now I'm going to click on. Now you should see it, right?
Yes. Yep.
Okay. I'll start from the beginning. Here we go. Okay. So, okay. So myasthenia gravis is called the snowflake disease because everyone with this disease is a bit different. And also the disease itself presents quite differently at different times in this course, but also even within the day itself. I can go to the grocery store feeling absolutely fabulous and come out of the grocery store feeling absolutely awful. So I do have a disability sticker, and that is why I use it. Or I can go to the museum and say, no, don't get me a wheelchair. I don't need that. And my family will say, well, we'll see. And halfway through, they will go find a wheelchair for me. It is really a disease that can find its way to change its course in a fraction of a minute. And we will see how that can alter things in a person, in a family, and in a community. Myasthenia itself means weak muscle in the Greek, and gravis means serious. So in essence, it means a seriously weak muscle. So we'll change if it will. Okay, So a little bit about myself then. We are global citizens in our family. This is a little bit about our journey. We've lived for 24 years in Kenya and 1 year in Eritrea. We have worked in international health and for World Relief, which is based here in Baltimore, and that's what brought us to Baltimore. We've been missionaries with Mission to the World, which is part of the Presbyterian Church of America, for almost 40 years. And we have 3 children, and one is living because at the age of 8, he had a very serious situation where he was swimming in the water and in a pool, pulled himself out of the pool and collapsed. And because the first responder came and revived him, he is alive. So we owe so much to all of you and the work that you do. And we're so grateful. He has lung QT syndrome, and we didn't know it. So we are so thankful. In fact, I gave it to him. I have the gene, and 2 of our 3 children have it, and a number of our grandchildren. So we certainly didn't know at that time that he had it, and we are enormously grateful to the profession that you have and the work that you do. I have been a nurse in public health, working in maternal child health and in HIV/AIDS care and prevention for many years. And we have witnessed in the course of our work, both my husband and I, a lot of trauma with coups, ethnic conflict in Rwanda, Burundi, Kenya, Sudan, the Democratic Republic of Congo, Cambodia, and even a kidnapping in Eritrea. I don't have time to go into all of that, but I just wanted to let you know that even through all of that, God has been very faithful to us and has brought us through so much, but we are still enabled by his grace to continue working. And we've seen great resilience in communities and in churches working together. And this is one example right here of these women working in public health through public health measures in northern Kenya, learning about better nutrition. And these sweet children in Burundi working and saying hello to you. Burundi is a country that's among the poorest in the world, a landlocked country, but these children are, as you can see, healthy and eager and very active. So the big impact here, you can see that even small measures in many parts of the world in health can have a huge impact. And here on the left, you can see that we call this a talking wall. It's actually a toilet, a long drop, but people are using it to give messages of hand washing. And on the right is a simple intervention of hand washing with a small amount of water. We call it a tippy tap, where you just tip the small container over, and you wash your hands with it, and it also waters the plant. This was our ambulance, and I wanted to show it to you in Eritrea, and it obviously had a little bit of problem. And believe it or not, there's a sign on the front there that you can see. It says 12 people only, because there weren't many cars or vehicles or means of transport in that very rural area. So sometimes the ambulance not only carried the sick, but a number of relatives or people to the hospital, and even some people along the way, because there just was nothing else. So I wanted to give you a taste of what it was like in rural Africa and in healthcare in that part of the world. And I don't know, do you all see the top bar that I see too? I don't know how to get rid of that.
So
Exactly.
no, we don't. We only
Oh, good.
see,
You can
we
see all
just
the
see your
words.
slides.
Good.
Yes.
Okay, great. So I wanted to share a little bit about public health and emergency care and some of the similarities here, because there's actually a lot that we can learn from each other. In public health, we are focused on prevention a lot, and in crisis intervention on life saving. In public health, the metrics that we use are looking toward planning ahead and planning for the future. So we think about nutritional public metrics and so on. And in crisis intervention, you're looking at metrics that look at life, death decision making, such as vital signs and so on. In public health, we look long term, usually in crisis intervention, some immediate and urgent interventions. In public health, we're doing a lot of teaching. We have time to do that. Of course, in crisis interventions, you're making quick decisions and you're doing quick assessments. In public health, we are community and family oriented. In crisis intervention, you are looking at the individual or all who are injured. And in public health, we're looking at a history, of course, but it involves health, social, cultural issues as well. And you are definitely looking at history in crisis intervention, the health history, the social history around the person, and crime or other issues that may intervene. And the environment is extremely important, the home, the family, the agriculture, the economic issues, the industry around, and also in crisis, the home, the environment, the home, the weather, the terrain, and so on. Those are just some of the things I was thinking about in terms of public health and crisis intervention. And both are so, so important when we're looking at health for the individual and person. So the one question I had here is that we're going to pivot a little bit now and look at if someone, as you enter a home, and I want you to feel free to just spout out any thoughts you might have. If someone that you think that as you enter a home says to you, I'm having trouble breathing, what would you do? Anyone have some ideas? I know you do, of course, but this is so, so important, because as I asked people living with myasthenia gravis, and this is a big issue, they gave me some of their answers, but I just want to first of all prick your thoughts. What would you do? I know you know.
So first we would assess their breathing.
Right. You would assess their breathing, and how would you do that?
Feel free to call out, everybody.
Yep, feel free.
Ask them how today's
Listen
worse
along.
than any other day.
I'm sorry, I didn't quite hear.
Ask them how today's worse than any other day.
All right, perfect. I'm so glad you gave that answer. Anyone else?
So someone said, listen to lung sounds.
Okay, great. Listen to lung sounds. Very good. All right, thank you for those responses. That was so, so helpful. These are some responses I got. I'm in a support group for people with myasthenia, and in preparation for this, I asked them. And these are some things that they wanted you to hear. I can't breathe and oxygen won't help. I can't breathe, but the pulse oximeter tells you I can. It's wrong, and I'm right. I feel short of breath even lying in bed. I can't breathe, I can't talk, I can't open my eyes, I can't move my legs, but I'm not having a stroke. So what is myasthenia gravis? Well, the description is that it's a chronic autoimmune. That means that the body's immune system, instead of protecting us, is attacking. And it's neuromuscular. And the impact is incredible fatigue, weakness in the skeletal muscles. Those are the muscles that connect to our bones and allow us to move around, both arms, legs, and allow breathing, as opposed to the smooth muscles, which, are the muscles that are for our circulatory system, for example, and in the digestive system. And weakness in eye muscles. And thankfully, it is not characterized by pain. So we are very, very grateful for that. And this is how it presents itself. Blurred vision or double vision, weakness in the eye muscles, drooping eyelids, one or both, changes in facial expression, difficulty swallowing, impaired speech, shortness of breath, weakness in your arms, hands, fingers, legs, and neck. So this is how myasthenia works. Our nerves send signals to our muscles to activate, and this happens at the neuromuscular junction. So much happens at that junction with chemicals and electrical transmission. And I'm not going to go into that detail. It actually is pretty complex. And that's where so much research is being done for medical intervention right now. In a person with MG, which is what we use for short, these impulses are interrupted by antibodies from our immune system working against our body instead of for it. Those crazy antibodies, they really wreak havoc with our system. And instead of working for us, they're working against us. And in some people, in most people with MG, those antibodies are detected and they're identified. In a few people, like myself, actually, they're not detected. So I'm actually antibody negative, but I still have MG. But most people, they can be detected. There is no cure, but there are periods of remission. And some people, there's one woman in my support group, the support group I attend, who was in remission for like 12 years or something. And she was just working very well and doing very, very well. And then she went right back into having problems. Medications help. Mestinon or pyridostigmine is a common one. It helps a lot with the symptoms, and people take it 3 or 4 times a day, but it's only for symptoms. So it will help your droopy eye. It will help with a droopy mouth or help with the fatigue. It interrupts the interruption at the neuromuscular junction. There's also what they might call a rescue intervention. It's intravenous immunoglobulin, IVIG, and that's given over a couple of courses of a few days. It's a highly concentrated collection of antibodies, like from 1,000 different people, which is helpful. But it's to get you kind of back on track. And it's not really, it's only good for a couple months, and then you have to have it again, or even maybe just a month. And then there's plasmapheresis, which is an actual exchange of your plasma, which is where the antibodies are. So they remove your bad antibodies and give you somebody else's good antibodies. That's very expensive, of course, and it's not always available. And that's really in a crisis intervention, usually that is done. There are immunosuppressant drugs or steroid treatment, which is given, and that's what I've been on, the mycophenolate, which has been keeping me very good for quite some time, but it does reduce your immune system and makes you more vulnerable infections and things like that. A thymectomy, which is a little gland, which some people still have as adults. Most of us, it kind of wears out and it's not really of any use anymore, but younger people still have it and be removed, which can be helpful. And then there are new drugs which are always kind of coming along and which can target at that junction that I talked about and can be useful. So it's still, actually, there's more and more research being done about this now all the time. In summary, then, it's a rare neuromuscular autoimmune disorder which causes extreme fatigue and profound muscle weakness. Impulses from the brain travel down the nerves but are blocked by antibodies before the impulse reaches muscle. And the body is essentially attacking itself and stopping muscle function. And it impacts the person's ability to see, swallow, smile, walk, breathe, or engage in normal everyday activity. So you can see it can be very serious. Results in drooping eyelids, which isn't terribly serious unless you want to drive or read for a living, which most of us do, have some sort of reading in our living for work. Double vision, smiling is troublesome, trouble breathing or swallowing, extremely weak arms, hands, or legs, profound tiredness, and impeded mobility and movement. This can be on a huge scale of difficulty. And it varies, as I said, as a snowflake disease from person to person and from time to time. So let's think about the emergency consequences. As a result of these conditions now, I'm going to ask you, what might you expect some of the consequences resulting in possible injury or emergency to be? Anyone?
So maybe falling.
Yes, definitely falling. And with possible very serious problems, right?
At times, can this be mixed diagnosed as a stroke or a TIA?
Exactly. That's a very common problem, a misdiagnosis. Anything else? Those are some of the main ones. Potential road accidents due to poor vision. And I can tell you from my own experience, I left visiting a family member in Pennsylvania. I was feeling absolutely wonderful. And as I drove down 95, evening began to come on. And then the weather turned bad and it was raining. And my eyes got tired. And the road got blurry. And the rain did not help. And the lights from the nighttime didn't help. And I actually really got scared because 95 isn't easy anyway. And there were so many lights and the road got very blurry to me. And I was really scared. I had to pull off. So potential for road accidents is really a serious thing. Falls at home, and it came on quite quickly. Falls at home or elsewhere due to weak legs and poor vision is another one. Choking with swallowing problems, respiratory crisis because of the problem with breathing. And the diaphragm is one of the muscles which is affected. And other medical crises complicated by MG, including an MI, a stroke or a diabetic crisis, which people with MG can still have. So these are very, very real issues which can happen. So anyone can be diagnosed with myasthenia gravis, though it's more common in adults than children, but children can also have it, and young people as well. In the support groups I'm in, we have someone in their 20s. We have individuals who've had myasthenia since they were children. We have individuals who are recently diagnosed who are in their 60s and 70s. I'm right now 73, and I was diagnosed only 4 years ago. So you can see it's quite a range. MG can occur regardless of race, gender, or age, but it is rare, only 20 in 100,000 people. So thankfully that's true. But in the US, about 70,000 people alone have this disease. But we are still trying to make people aware of it because of the consequences of people not being aware, especially in your profession, can be quite severe. And here are some case studies. And these I gleaned from the support group itself. So these are very real from right in this area. One support group is Glen Burnie, and one is also in the greater DC area. One woman picked up by police in Washington, DC was presumed to be drunk because she was walking and weaving around as she walked. The woman also had slurred speech. Another case study, before I was diagnosed with MG, I was picked up by first responders at home during COVID. I could not breathe completely well, and my speech was slurred. I could not open my eyes. My pulse ox and vitals were okay. Because of that, they left me alone in the ER waiting room. I could not talk or see or breathe. From my perspective, I thought I was dying with no one to advocate for me. And then another woman told me I could not use my arms or legs. My breathing problems were subtle and could be easily overlooked. I felt like a rag doll, and I suddenly felt so vulnerable. Heaven knows what they thought of me. My doctor called ahead to the ER. And finally, a male said to me, I intentionally did not use paramedics. I did not want to be intubated. Their number one protocol is to use oxygen, which doesn't do much good for MG. It is the mix of carbon monoxide buildup that we struggle with. Invite them to join us to a support group meeting. So you are invited. So now, hopefully, yeah, I'm going to invite you to listen to this video.
University of Vermont.
I hope you can hear it.
And we're going to be talking to you today about emergency management of myasthenia gravis and giving an overview for first
Can you hear it okay?
Yes, we can hear it.
Yes.
So myasthenia gravis is a autoimmune neuromuscular disorder. That's rare. It affects about 20 per 100,000 people, but it is a disorder that affects people of all ages. And the hallmark of this disease is that it causes muscle weakness. And like many diseases in neurology, it has a predilection for specific muscle groups. And in myasthenia gravis, we often see weakness in people's eye muscles, both the muscles that move the eyes as well as the muscles that lift the eyelids. We see weakness in the muscles of the face, including the mouth and the muscles that close the eyes. We can see weakness in the muscles that help folks chew and swallow. We can see weakness in proximal limb muscles, so shoulders, hips, and sometimes the neck. And we can see weakness in breathing muscles. And one of the things about myasthenia gravis is that often when patients are affected by this disease, the more they use their muscles, the more likely they are to be weak. And patients often experience some improvement if they rest for a period of time. So we're going to go through some of the signs and symptoms of myasthenia and look at some of the different patterns of weakness that you might see if you encounter a patient with this disorder. So many patients with myasthenia, the overwhelming majority of patients will have some weakness in the muscles that move their eyes and the muscles that lift their eyelids. This picture is depicting a patient who's showing evidence of eye muscle weakness on the left-hand side of the screen and then having it corrected on the right-hand side of the screen. And what we see is a drooping of the right eyelid here, indicating that that muscle seems to be weak. And if this patient were to look up for a period of time, that droop may actually worsen. We also see that the eyes are not looking at an image in the same place. His left eye is sort of upward deviated, and the right eye is sort of pointed in. And this patient, when symptomatic, is likely experiencing the symptom of double vision. And then with medicine, you can see that the eyes become conjugate and the eyes are more open. This next patient is showing evidence of facial weakness. And when we see facial weakness, we often are also worried that there may be bulbar weakness, which we'll discuss in a second. So in the picture, what we see weakness of the mouth muscles here, where patient is trying to smile and is unable to lift the corners of his mouth. On the right-hand side of the screen, you see the patient trying to squeeze his eyes tightly shut and is unable to do so, suggesting that those muscles are weak. The next thing one might test in a patient like this is to have the patient count out loud. We'll often have the patient count out loud to 30 or 40 and listen to the quality of their speech. In myasthenia gravis, it has a predilection for the soft part of the palate. Patients often have air escaping from their nose when that muscle is weak, and they sound a bit nasal, or I like to tell my patients that they sound like they have a French accent when they're weak. When you hear the change in the voice, when patients have that change in their voice, we also are concerned that they could be having trouble with chewing or swallowing. They could be at risk for aspiration or occluding their airway. So it's important when you see bifacial weakness like this, or you hear the change in the voice, that you think about weakness in muscles of chewing and swallowing, because this can become a big problem, especially in the emergency setting. Patients can also have generalized weakness. The overwhelming majority of patients with myasthenia have difficulty holding their head in flexion. So if they were laying supine on a bed, they would have trouble lifting their head up off the bed if they had some neck weakness. And it's very, very important when you're assessing the patient in the emergency setting to look at that strength. It takes 2 seconds to do. Your patient would likely be on a stretcher anyway. And patients who have difficulty with neck flexion often are also having difficulty with their breathing muscles at the same time. It's a good surrogate muscle group to examine for that symptom. Patients can also have weakness of their arms and legs, so they might have difficulty lifting arms up overhead, or they may have difficulty getting up and down out of a low chair. And then patients with myasthenia can get shortness of breath, and they'll feel short of breath in a couple of different settings if their respiratory muscles are becoming weakened by this disease. A patient might feel short of breath if they're laying down, if they're having to work harder against gravity. They may feel short of breath with exertion, or just minimal exertion, or just with talking. And if a patient is becoming very, very severe enough that maybe they're requiring emergency services in the home, you may see paradoxical breathing. You may see that they're breathing quickly, or they may have difficulty with coughing. And again, just this slide just emphasizes the fatigability of muscles in myasthenia. So this woman is looking upwards, and you can see after about 10 seconds of gaze in the middle photo, her eyelids are starting to close on her. And by 30 seconds of upgaze, you can see that the eyelids are almost completely closed. And this is just an illustration, but this could be any muscle group, including breathing muscles. So if the patients are working hard to breathe, it's important that they be assessed and taken care of quickly, because they may progress to failure, and it's something that needs to be assessed.
that was an excellent introduction to myasthenia and how myasthenia presents. So for the next part of the talk, we're going to talk about different scenarios that a patient with myasthenia would call EMS in. And we're going to go through a couple of cases to illustrate certain clinical challenges that might come up for the first responder. We're going to talk about three different situations. The first is the patient with known myasthenia who has another health issue, like a heart attack or a stroke or an allergic reaction or trauma, who's calling EMS for that other reason, and they just happen to have myasthenia. We're going to talk about how the myasthenia might influence your assessment and management of those patients. The second scenario is a patient with known myasthenia who has worsening of the myasthenia or myasthenic exacerbation. They might even have impending myasthenic crisis or respiratory failure. This patient is calling EMS or seeking emergency care because of worsening of their myasthenia. And we'll talk about some factors to consider when addressing those patients. The third patient is a patient with symptoms of myasthenia who hasn't yet been diagnosed. So you might come across a patient who has all of the signs and symptoms or some of the signs and symptoms that Dr. Hare walked through and illustrated, but doesn't yet have a diagnosis of myasthenia. Yet if you see those symptoms, you might consider it on your diagnosis and be prepared for the fact that there may be respiratory or airway issues. So the first scenario, the patient with known myasthenia. So how does myasthenia interact with the care of other acute medical problems? Well, sometimes it's a challenge to understand what's old and what's new in a patient's presentation. For example, the patient with myasthenia who has chronic double vision and slurred speech has a new stroke, and potentially one that causes double vision or slurred speech or other symptoms. So understanding what's new in terms of the patient's deficits and what's old in terms of the patient's myasthenia is really important for that patient. The second example would be, for example, a patient with myasthenia who has slurred speech, and understanding that that slurred speech is due to the myasthenia and not due to some other problem like intoxication or stroke. And we just heard about the type of slurred speech in myasthenia, which has a real nasal quality due to weakness of the soft palate. The other time that myasthenia can complicate the care of other acute medical problems is when the standard treatment for other conditions could potentially worsen myasthenia. So what does that mean? Well, the patient with myasthenia has an acute MI and is given beta blockers for treatment of that. Well, we know that beta blockers are indicated in the treatment of MI, but they can also potentially worsen weakness in myasthenia. And so as emergency providers, we need to be prepared for that. Patients may carry a list of medications which can worsen myasthenia, or they may require that we reference them as providers. Again. For all patients with myasthenia, there are a couple of principles that we can keep in mind for care. The first is, if we learn a patient has myasthenia in the pre-hospital setting, alerting the emergency department to the fact that the patient has myasthenia. The second thing is always making the patient comfortable. So we know that stress and heat are known triggers that may exacerbate weakness in myasthenia. And so keeping the patient relaxed and cool in an ambulance or the pre-hospital setting is very important. If the patient is having trouble breathing or swallowing, the patient will want to sit up to help keep the airway open and make breathing easier. So having the patient sitting up, elevating the head of the stretcher helps with breathing, can help with swallowing, and can help maintain an open airway. When talking to the patient with myasthenia, what kinds of questions do you want to ask them about? You want to ask them about the patient's typical symptoms of myasthenia, especially whether the patient has a history of difficulty breathing, so in terms of myasthenic crisis or difficulty swallowing. You want to ask about current medications that they take for myasthenia and other medical problems, and whether the patient carries a list of medications to avoid or use with caution in myasthenia. And again, alerting the emergency department to the fact that the patient has myasthenia is important. So what kind of therapies may patients with myasthenia be taking for treatment? Typically, patients may take both symptomatic and immunosuppressive therapies. Symptomatic therapy is taken several times a day or as needed to treat weakness of myasthenia in the moment. The symptomatic therapy that's used is called pyridostigmine. Patients may also be on immunosuppressive agents such as prednisone or steroid-sparing agents such as azathioprine or mycophenolate mofetil, and they may receive infusion therapies like rituximab or eculizumab. They also may have previously or received or currently be receiving rescue therapies such as IVIG or plasmapheresis, and they may be receiving experimental trial drugs that it's important to know about. So the bottom line is that most EMS standard of care is fine for myasthenia. The exception to that is the medications to avoid or use with caution because they may worsen symptoms of myasthenia. This is a partial list that we've referred to a couple of times, and the full list can be found in an updated form at myasthenia.org. A couple of medications to note in particular are magnesium, IV steroids, certain cardiac drugs like beta blockers and calcium channel blockers, and common antibiotics such as quinolones, aminoglycosides, and macrolides. Neuromuscular blocking agents can also worsen weakness in myasthenia or have unpredictable effects, particularly non-depolarizing agents. If there is any question about what medication to use in a patient with myasthenia, it is always best to contact medical direction. What are some additional special considerations for patients with myasthenia in the pre-hospital setting? Well, in situations of trauma, myasthenic patients may have weakness which can complicate their transport or immobilization. And again, stress and pain may exacerbate symptoms of myasthenia, and so keeping the patient calm and trying to control pain is paramount. Patients who have allergic reactions that might be treated with IV steroids can experience worsening symptoms of myasthenia. If a patient with myasthenia has a heart attack or MI, several cardiac medications can worsen symptoms of myasthenia. As we talked about, if a patient with myasthenia has stroke, symptoms of myasthenia can mimic a stroke, and stroke can mimic myasthenia. And so understanding what's new and what's old is very important. If a patient with myasthenia presents with choking or aspiration events, we always want to consider whether worsening weakness from myasthenia was the cause of the aspiration. Many patients with myasthenia are on immunosuppressive agents, which can predispose them to infection. And lastly, when women with myasthenia become pregnant, if they were to call EMS in the pre-hospital setting, they would be transported to the nearest tertiary care center with a NICU capacity, particularly if they were close to delivery. And it's important that pre-hospital providers understand that newborns of women with myasthenia may have transient weakness, which presents as a weak cry, trouble breathing, and difficulty swallowing. to be prepared for that should the woman deliver en route to the hospital. So let's talk about a couple specific cases. The first case is a 28-year-old woman who was working as a school teacher who had Myasthenia Gravis and a history of myasthenic crisis, who called EMS with shortness of breath. We learned more about her medical history and learned that she undergoes rituximab infusions and takes prednisone for her myasthenia. And she had recently been tapering her prednisone because her symptoms had been stable. She had been sick recently with a cough and a fever for the past 3 days, which had improved. And she had been prescribed a Z-Pak recently for her illness, which is known to be a medication which can worsen or exacerbate symptoms of myasthenia. When EMS arrived, she reported feeling short of breath for several hours, and she reported difficulty swallowing and neck and arm weakness. Upon EMS arrival, the patient was conscious, alert, and oriented ×4, and she appeared anxious. She was speaking in full sentences, but with slurred speech. Although her speech was slurred, she was still able to be understood. She denied alcohol consumption or other drug use. And on careful examination, it was noted that she had mild eyelid drooping, she had excess salivation, and had difficulty controlling her secretions. She was holding her head up with her hand due to neck weakness, and she did not want to lie flat on the stretcher due to shortness of breath. On strength examination, she had at least anti-gravity arm and leg strength and was able to walk. Her vital signs revealed that she was afebrile, her heart rate was 90 and regular, her blood pressure was 130/80, her respirations were 18 per minute, and she was satting 98% on room air. So with that case presentation in mind, we're going to talk for a moment about myasthenic crisis. So what is myasthenic crisis? This patient had a history of myasthenic crisis and mentioned that. And what that means is that she has had an episode of severe muscle weakness due to her myasthenia, which has led to respiratory failure, which required a need for mechanical ventilation or non-invasive ventilation. All other exacerbations of myasthenia, even if they are severe, are called exacerbations and not deemed true crisis. And what can cause myasthenic crisis? Well, illness is a common trigger of myasthenic crisis. Infection, as we mentioned, might be a trigger in the prior case. Surgery, and patients with myasthenia sometimes undergo thymectomy, either for removal of what's called a thymoma or for treatment of their myasthenia. And this surgery or other surgeries can worsen symptoms of myasthenia. Pregnancy or the postpartum period can cause myasthenic exacerbation and crisis. Tapering medications for myasthenia, like in the case of this patient who was tapering her prednisone, can cause worsening of myasthenia and crisis. Sometimes the patient will take a medication that can cause worsening of weakness, stress, and heat, as we talked about. And sometimes there is no identified trigger for worsening of myasthenia or crisis. So how do we recognize when somebody is just having worsening of myasthenia versus when they're in impending myasthenic crisis? Well, the first thing that we do is we count the respiratory rate. Tachypnea and rapid shallow breathing is a sign of stress and neuromuscular respiratory weakness, and this rapid shallow breathing is used to compensate for increasing muscle weakness. It is common for these symptoms to mimic anxiety or panic attack. But in myasthenia, we don't want to assume that tachypnea is due solely to anxiety. We look for signs of increased respiratory effort. And we can do this by checking underneath the clothing for evidence of retraction or use of accessory muscles of breathing. We observe or get a history of the patient having difficulty lying flat, and we see the patient speaking in short sentences, observe a weak cough or increased secretions. And we understand that respiratory muscles, if they are involved, may fatigue during the course of the encounter and produce a precipitous respiratory decline. What are things not to rely upon to recognize impending myasthenic crisis? Well, pulse oximetry is one of them. It is not a reliable indicator of respiratory status in myasthenic patients. And just because a patient with myasthenia has a good oxygen saturation does not mean that they are not having respiratory problems or potentially heading in that direction. Hypoxia is a late sign of respiratory dysfunction in myasthenia, and it's typically only seen after life-threatening respiratory failure has already developed. So in summary, unstable myasthenic patients present with dyspnea, tachypnea, orthopnea, use of accessory muscles to breathe, reduced breath sounds at the lung bases, slurred speech, trouble swallowing secretion, trouble holding up their head, difficulty lifting their head up off the stretcher, and difficulty walking or sitting independently. A quick bedside measure of respiratory status is what's called the single breath count, and patients with myasthenia may even be familiar with this. It's performed by asking patients to count in a normal speaking voice after maximal effort inhalation, and they count at a rate of 2 counts per second. In general, an ability to count to greater than 50 is entirely normal, and an ability to count to less than 15 indicates dangerously reduced strains of breathing muscles. The single breath count correlates well with the more formal measure of respiratory function called the forced vital capacity. A reduced single breath count test is a red flag. So getting back to our patient, we assessed that her myasthenia is unstable. Her single breath count was 20. We had significant concern for impending myasthenic crisis. In her case, precipitating factors included illness, the steroid taper, and a medication which can worsen myasthenia. She had taken a Z-Pak or azithromycin for her upper respiratory infection. And she also had a history of severe myasthenia and myasthenic crisis, which let us know that her disease had even more potential to decompensate. We decided that urgent transport was needed, and this was considered a neuromuscular emergency with impending respiratory failure, despite essentially normal vitals. In terms of pre-hospital management, the head of the stretcher was elevated to at least 30 degrees, suction was ready. If breathing is inadequate in these patients, EMS can provide assistance with ventilation immediately according to local protocols for the level of training. For basic EMTs, this often includes a bag valve mask. For advanced EMTs or paramedics, this would apply CPAP or assisting the patient with their own BiPAP. And of course, medical direction is available with any questions. Placing oxygen alone on the patient will not alleviate respiratory distress in myasthenia without these other measures. In fact, in patients with chronic respiratory failure from muscle weakness, oxygen can decrease respiratory drive. Invasive ventilation is needed when airway patency cannot be maintained or when non-invasive ventilation is unsuccessful. Rapid sequence intubation should be modified. Neuromuscular blocking agents should be used with caution when intubating myasthenic patients, and an awareness that depolarizing agents such as succinylcholine may be less potent in myasthenics is important. Patients are transported immediately to the nearest emergency facility, and again, alert the ED that you're transporting a patient with myasthenia. So what happens next?
So what happens next? You've picked up this patient. What's going to happen to them after they arrive at the emergency department at the hospital? So patients who have impending respiratory failure from myasthenia will continue to get positive pressure ventilation in the emergency room setting, either with use of a BiPAP, or if the breathing is becoming so severe they may need to secure an airway and put the patient on a ventilator. Medical treatment will start at some point after their arrival at the hospital. And typical short-term therapies when a patient is admitted for myasthenia is either plasma exchange, which looks a little bit like a dialysis machine, which is depicted in the top part of the slide, and that pulls off patient's blood, and it gets separated into the cells, the red and white blood cells, and the plasma, which is the fluid that bathes the cells. We throw away the plasma, the fluid that bathes the cells, and then give a patient back their own red and white blood cells. And the antibodies that are the cause of myasthenia live in the plasma, so we're kind of throwing away the bad actors. And usually patients will get a course of about 5 plasma exchanges, sometimes called plasmapheresis, depending on what you're replacing the plasma with. And that usually occurs over about 10 days. So they get a therapy every other day. And usually by the 3rd or 4th exchange is when their weakness starts to improve. Patients may also, if that's not available, receive intravenous immunoglobulin, or IVIG, which is pooled antibodies from thousands of donors. And this modulates the immune system. One of the big differences between the two is that the response to that medicine may be a little bit less predictable in the early part of the hospitalization, but if you look to the end of the hospitalization, plasma exchange and IVIG are close to equivalent. But it is the recommendation of an international consensus guideline to use plasma exchange in these patients if it's available. Eventually, if a patient isn't already on steroids, we'll add them at some point during the hospitalization, but they're often avoided early in the course of the hospitalization because in many patients, it's very predictable that for the first 5 days or so that they begin or increase their dose of steroids, they can have a worsening in their muscle strength. And if a patient is having difficulty with breathing, or a patient is having difficulty with their chewing or their swallowing, we wouldn't want those to be worsened by a therapy that we give them. Another short-term therapy not on the slide that we may also be providing the patient at the same time is acetylcholinesterase inhibitor, like the pyridostigmine you heard earlier in the presentation. I think an important point to make for these patients is that their prognosis, if cared for appropriately, is very good. And I always emphasize this when I talk to folks who care for patients in the ICU or who care for patients in the emergency setting. Unlike many neurological patients, patients with neuromuscular disorders who are having breathing dysfunction actually have a pretty good prognosis with diseases like myasthenia. So on the right side of the slide, you can see that at the turn of the century in 1900s, myasthenia had a very poor prognosis, and most patients would die from this disease. But as we got better at ventilating patients, as we got better at treating patients with immune-based therapy, now mortality from myasthenia is probably less than 5%. So it's a very treatable condition. If they're treated appropriately, if you look at myasthenia patients, if you compared them to all neuromuscular patients, which might include patients with things like Guillain-Barré syndrome or other conditions that cause neuromuscular weakness, myasthenia patients on average are ventilated for about 5 days if they have crisis, and they'll spend about 10 days or so in the ICU. And a lot of that is that it takes 10 days to really give the plasma exchange. And you want to be sure before you transfer a patient out of the ICU with myasthenia that they are improving. Because what you don't want is to transfer one of these patients out of an ICU setting and have them get fatigued on the floor and go back into respiratory failure in a setting where they're less able to care for that. So we can look at another case. So this is a second case, and this is a 67-year-old gentleman with a year of myasthenia gravis who had the acute onset of right face, arm, and leg weakness and slurred speech, and was previously normal 15 minutes ago. And we know that his myasthenia was restricted to eye movement abnormalities in the past. And we also know that he had some risk factors for vascular disease, including hypertension, hyperlipidemia, and diabetes. He was on some medicines to treat those things, including antihypertensive agents, and aspirin, and a statin medication. And he had no recent changes in his medicine for myasthenia. And what we find is that there's some eyelid drooping, ptosis, but the patient has a right arm and leg drift and weakness on that side. He's having trouble moving the lower portion of the face. You find that the patient has an irregular heart rate. They're a little bit hypertensive, and they're shown to be in atrial fibrillation. And the difference between this patient and the previous patient was really the presentation. It was a very acute onset problem, unilateral on one side of the body. In the setting of atrial fibrillation is much more consistent with an acute vascular injury to the brain, such as a stroke, than it is to myasthenia. And the red flags for that are the acuity of the onset. Usually in myasthenia, it takes some time to develop the weakness. The patient, gets fatigued over hours. It's not something that hits suddenly like a thunderclap or a lightning bolt, as a stroke does. In addition, this patient had pretty stable myasthenia, and he had vascular risk factors, which raised the stakes for a different process. So I think it's really important, as Dr. Gadon discussed earlier in the talk, that it's really important that even though patients have myasthenia gravis, or even if they have some other neurological illness, you have to consider that they could have a new process like a stroke, as illustrated in this case.
So in terms of take-home points, we talked today about how myasthenia gravis is rare, but important for first responders to know about. Myasthenia can cause respiratory failure. And in the respiratory failure related to myasthenia, pulse oximetry and other vitals are not a good measure of how stable the patient is. In many situations, the patient's myasthenia will not significantly influence standard treatment in emergency situations. And of course, always alerting the ED that you're transporting a patient with myasthenia is important. So thank you very much for your attention today, and we hope that this webinar was informative.
Okay, great. Let's review. Thank you so much for listening to all of that. I'm going to wrap things up here, and then we can take some questions. Let's review some of the takeaways from what we've learned so far. That myasthenia is a snowflake disease. Everyone is different, and the disease is different at different times, even of the day, and in different seasons. It's a neuromuscular disease. It affects muscle groups of the eyes, the face, the mouth, the neck, the breathing muscles, arms, legs with fatigue of varying degrees. It can be extreme and present a respiratory or choking crisis. And certain conditions aggravate myasthenia worsening, like medication, stress, heat, infections, illness, surgery, tapering of meds, pregnancy, or postpartum. I thought the video and the two physicians did such an excellent job of reviewing all of this for us. In the home, assessing the airway and breathing is so critical, determining what is old and what is new, getting a list of the medications, remembering that you cannot rely on the pulse ox or vitals only to determine if the patient is having respiratory problems. There's nothing like observation, right? You know, really looking at those respirations and the whole person, counting them, determine if there's difficulty lifting the head or lifting the hands over the head, slurred speech, difficulty walking. These are simple measures, but they will tell you a lot. The single breath count, less than 15, is very dangerous. And I learned something myself this time, by the way, that there were 2 breaths per second, which is important because when I was in the doctor's office, I tried to do it real fast so I could get the 30 or 40 or 50 in. So don't let your client do them real quickly. I thought that was pretty interesting. So the two per second is pretty important. The standard of treatment that you all have is usually considered safe. And I think that should be very reassuring to you that you have the tools and the protocols that are important to use. There were some exceptions concerning the medications, but you can review them and maybe even have some of them available in a list somewhere that you can get through the myastheniagravis.org. Alert the ER in the ambulance for sure, or at the home, that you're bringing in a person with MG. By the way, not all emergency rooms know about it, or emergency departments. Not all physicians know about it. Monitor respiratory situation constantly and be alert that changes can happen quickly. Oxygen alone does not help. Be sure that and use appropriate assistance for airway that you're qualified to use. Raise the bed for comfort and breathing. That was pretty evident and in the video. Keep the van cool. Definitely heat can trigger exacerbation. Avoid medications on the MG list, and they were listed there. So those are just some quick summaries that are very, very relevant to what you do. And I have one final slide for you, and then we will take some questions that you might have, and I hope you do have some. And here it is. This is an African proverb, and I just wanted to leave you with a global touch. The fuel of the lamp is consumed, yet it provides light for others. And as I thought about the incredible work that you all do day and hour and night after night, you must feel very often that you are consumed. And we want you to know that your work is not in vain, and that light shines brightly and it provides health and healing for so many. This lamp is one that was used in Papua in Indonesia. It was fueled there at a training like this one. And it went out to the villages that were very distant. And it continued shining and providing help and health and healing to far distant places. And at doorways like this one, where this little boy was standing, it provided some help and hope. And you also provide a lamp and hope and health in many, many different homes and doorways where people are waiting for that urgent care and help that is so needed. And we are so grateful. And I'm so thankful that you wanted to listen to this and learn about something that, yes, is rare, but will be something life-giving to that family or that individual that has someone with myasthenia who is waiting for the hope and the strength and the help that you will provide. So I will take some questions now, and any comments as well that you might have, something that you've learned or something that you want to share from your own experience, whether it's in this regard or some other respiratory issue. Please, I'm all ears and would love to hear from you.
Debbie, first of all, I just wanted to thank you so much for taking the time to talk to us today. I know myself, I learned an amazing amount about a condition that I had no idea even really existed prior to speaking with you. So I just wanted to thank you so much for taking the time to talk to us and give us a little bit of information about something that other people may not know much about. So for questions, people feel free to ask questions if you want to unmute yourself and ask. If you don't want to ask directly, I have the comments open and am happy to ask your questions for you.
I have a quick question. Just curious if you know, Debbie, are there quite a few MG patients who sleep with CPAP or use CPAP on a regular basis? Is that something that folks would tend to feel, like they had experienced before or would be comfortable receiving that kind of treatment? It's one thing we run into often is patients who have not done that before, who are at that point of crisis, having quite a bit of resistance to receiving that kind of treatment. I'm just curious if you know if that's something that's fairly common for people to use on a daily basis.
I don't really know. That would be an interesting question to ask. In the support group I'm in, I have a suspicion that a lot of people do, but I don't have any data on it. And but I could find out and I'll let you know.
Okay. All right. Thank you.
I'm curious if anyone has had any experience or known anyone with myasthenia at all. Have you heard of it before?
My father-in-law is was diagnosed also along with Parkinson's, so he's fighting both of those now. It's kind of a balance they're working on.
That's not easy, Brett. Do you have anything to share from your experience?
Honestly, before hearing about this, we've actually took him to the this is several years ago. We took him to the hospital several times thinking he was having TIAs because that's how he presented, very weak, the eye droop, slurred speech. And so not knowing about it at that time, not knowing of MG at that time, we had transported him at least 3 times thinking he was having TIAs, and it took a long time before he was ever diagnosed with MG.
Yeah, that's quite typical. Almost everyone in our support groups will say that it can take years before they find the doctor or the treatment that is helpful. They finally get the diagnosis. So I'm grateful that he did finally. Is he on some treatment now that is helping?
He is. I'm unsure of which exact medications he's taking. However, he's a very stubborn man and tries to dial in his medications on his own, which, as you can guess, has not always gone in his favor. It's actually made things worse at times because he was feeling really good about the situation, and all of a sudden he would have a flare up and become very bad again. I think he finally got into the point where he will stop adjusting his medications. However, he's an old, determined farmer, and will, as soon as he starts feeling really good again, he will adjust his medications again. It's just a matter of time.
Yeah. Yeah, I would recommend that he dial into our support groups. It's all on Zoom. We have people from New York that dial in. We have people from all over. So it doesn't matter where you live. And I can let Lindsay know the contact. So it's really, really helpful because there are gentlemen in the group that have that he would find a real sense of camaraderie with, I think. And
I'd really appreciate that contact, and Lindsay can get a hold of me offline at some point.
yes, that would be fantastic. There's nothing like finding someone who has been through it, you know, and understands what it's like. So we'll do that.
Debbie, I had a question about, there was one part of the presentation that talked about how a patient had taken a Z-Pak and it actually had exacerbated some of their MG symptoms. Do you have any insight on why that would cause an exacerbation, or is it specifically just to MG, or is it something that is seen in other autoimmune diseases as affecting a patient who has taken a Z-Pak?
Oh, a Z-Pak. I didn't quite get the first part.
Oh, I'm sorry.
Right, the antibiotic, the Z-Pak. No, I don't know why certain antibiotics do, but they do. And we need to avoid them. So it may not happen all the time, but it's certain types, some of the quinolines, the aminoglycosides and the macrolides. It might not, sometimes it's you really have to weigh the benefit versus the risk. So it's a real problem for me because some of the drugs you take really raise your risk of infection. And so when you get an infection, you don't always know what antibiotic is going to be effective. But I'm not sure they understand why. The risk.
Interesting. I thought it was something that was worth at least asking.
Yes, yeah, or if it's just true with other autoimmune diseases. I think that was your question. I'm not sure that's the case, but it's worth exploring. I have another autoimmune disease as well, ankylosing spondylitis, and it's not true with that. So, but I don't know.
Interesting.
Mm-hmm.
Does anybody else have any other questions? Anything that you either would like to ask, or I can ask for you in the comments?
I had a question about the presentation when you're having a myasthenia gravis crisis, because the presentation said that it was different from a stroke because it was so sudden. But I know at the beginning of your presentation, you had mentioned that symptoms can be very sudden for MG. So is it just with like a crisis that it would be different in presentation from a stroke that way?
Yes, that's right. A crisis is not sudden usually. A crisis usually builds over time. So like a stroke can be sudden, right? You have a sudden loss of of movement or something happens quickly. That's why your question of is this new or old is so important. Did this happen quickly or suddenly? And the case study they gave is this happened 15 minutes ago. That would be something that would alert you to maybe a stroke. But with myasthenia, with I was diagnosed with myasthenia because all at once in church, I saw two pastors in the front. And that happened quickly. And I closed one eye and I saw one. And my ophthalmologist had told me if that ever happens, you need to go to the emergency room.
Mm-hmm.
So I did. And they worked me up for a stroke, which I wasn't having. But the other possible diagnosis was myasthenia. So that was a new thing. Or the example I gave you of driving and feeling like things were getting blurry because my eyes were tired. And now it was the end of the day, and they had a right to be tired. So it did seem like it happened more quickly. Or I can be fine in the morning. For almost every myasthenia person, you feel better in the morning. And so I will swim in the morning, but at the end of my swim, I'll just collapse and I need to rest for a half hour or something, and then I'll feel better. So things can come on more suddenly and you don't expect it, which is why it's sometimes hard to plan or predict, but it's not always that way. It's not always that way. Yeah.
I think also in the second presentation, they were saying that myasthenia crisis or a myasthenic crisis is usually paired with respiratory distress and respiratory failure. So stroke is usually a sudden onset. So asking good questions when you're doing your assessment, and then determining if the patient also has some kind of respiratory distress in conjunction with that can determine whether or not the patient is having a TIA or if they're having something related to MG. I think Haley, I think that was kind of your question.
Okay. Yeah, that makes a lot of sense. Thank you so much.
Mm-hmm.
Mm-hmm. Right.
Anyone else? Any questions? Okay, well, if there's no more questions, again, Debbie, I want to thank you so much for sharing your experiences and sharing some information with us about MG and giving us tips on what to look for. It seems like it can be something that's incredibly scary. So if we can help our patients in any way possible, I think that more information is better. So thank you so much for your time. I really appreciate you being here with us.
You're so welcome. And thank you for all that you all do.
All right. So everybody, unless you have another question, that's it for this evening. I will be posting this discussion on our YouTube channel tomorrow once I have everything uploaded. If you have a question and you weren't able to ask it tonight or you think of it later on, please feel free to email me and I will get you an answer from Debbie as quickly as I can. But again, thank you all so much for taking the time to be here, and thank you, Debbie, and I hope you all have a wonderful night. Thank you so much.
Bye-bye.
Bye, everybody. Thank you.
Thanks. Bye-bye.